us to have this webinar with two very well-known prosthodontists. In the past, our webinars in the perio sector has been primarily around periodontitis, implantitis, and we'll continue with those arenas. However, there is a significant indication for using the erbium chromium YSGG because it is an all-tissue laser and is for both bone and for soft tissue. To bring in two individuals relative to looking at the aesthetic component of the erbium chromium YSGG laser. I was able to meet with Doctors Matrani and Goldberg not too long ago at SPEAR, and where Dr. Matrani is a resident faculty member there. And in doing that, we exposed both of them to the I+ erbium chromium, and then they took it from there. I will go ahead and introduce both to you. Dr. Ricardo Matrani practices in Mexico City. His original dental training was from in Mexico. Then he went on to the University of Washington, where he got a certificate and master's of science degree in prosthodontics. He continues to be a faculty member there, but also is on editorial boards. And his practice in Mexico City is limited to prosthodontics, implant, and aesthetics. Jack Goldberg, also original dental training in Mexico, then went on again to USC to not only get a certificate in prosthodontics, but also got a master's degree in oral-facial areas. If you've seen their photography, their cases, then you know the things that they have published with SPEAR is just phenomenal. And when I decided to go beyond just the periopathology, they were the first two names that I rang up. And so now we're going to have a little different, interesting component here to what the erbium chromium YSGG can do. And so with that, Doctors Matrani and Goldberg, please share some of your knowledge base that you've shared so for many years with SPEAR.
Well, thank you. Thank you so much, Sam, for the kind introduction. Thank you, David and Nathan, for hosting us today. It is certainly a pleasure to be part of this webinar with you all. And we look forward that that the content that we're going to be sharing will be useful, and hopefully this will be a set of ideas that everybody can incorporate come tomorrow morning or the day after. And so when Sam approached us and said, let's talk a little bit about achieving ideal aesthetics and the potential clinical application that we found utilizing our water laser, the erbium chromium laser, you know, it's part of a broader picture that we need to acknowledge. And when we look at the aesthetic, if you will, framework today, or the way that we practice interdisciplinary dentistry, we really think that one very compelling way of framing this concept is through the lens of being as minimally invasive as possible. And so what we want to do for the next 15 minutes or so is kind of cement this notion that less is more, and we utilize the right technology and the right procedures to ensure, whenever possible, that we do less dentistry. As you mentioned, we live in Mexico City, and I'd like to welcome all of you that are logged in. And I see that we have folks from Nigeria, from Singapore, from the US, of course, from Mexico. So it's really, really cool to be able to feel, at least virtually, this global flair, if you will. And so thank you all for joining us. Yeah, just a couple of images of our practice here in Mexico. We are very proud to have a very solid team of clinicians. Hey, we have somebody from Amman, Jordan, just saying hi as well. So as I said, our team is it's a solid team, and what we're going to be doing today is sharing some of our clinical work. Just in case you want to get a hold of either Jack or myself, and today's world, it's all about social media and mainly Instagram. Please feel free to follow us or to post questions also beyond this webinar via the DM function in Instagram. Follow our feeds if you want. We'll be happy to entertain as many questions as you shoot our ways. Jack, would you like to introduce yourself real quick before we begin the clinical content?
Yeah, I just want to thank you all, and thank you, Ricardo and Sam, for the invitation. I'm very happy to be here. We've been using the laser for over 3 years maybe now, and we've had a great experience, and we're very happy with it. So we're happy to share our experiences and to go over a few of the procedures that we use here in our practice every day.
Awesome. And so again, framing the set of ideas that we're going to be sharing today through the lens of aesthetic dentistry, and what does it mean to achieve ideal aesthetics? Well, we all know that aesthetics is a very broad term, and clearly it has to do with being able to connect with the patient's needs and to provide the patient with whatever their concerns and their desire to have whenever feasible. So this patient here, a very nice patient of ours, we went through interdisciplinary therapy with her, went through orthodontics. Initially, she had a very large diastema between her centrals. And then we did these ceramic veneers with basically little to none preparation. So conceptually, and this is, again, the way that we'd like for you all to start thinking about how and where dentistry is at this day and age, regardless of where you may practice. Because we really believe that we're living in a little bit of an intersectionality between, on the one hand, healthcare. So we are healthcare providers, but we're also practices and clinicians that see patients walking in through our door and are really concerned about lifestyle. And the third aspect of this intersectionality is definitely technology. And so this is, in a nutshell, where I believe dentistry lives right now. So we cater to our patients, providing them healthcare, but also when it comes to enhancing their aesthetics, it's part of their lifestyle. And sure enough, they want us to accomplish this by the most sophisticated technological means, to do so in a way that it's as minimally invasive as possible, and which means that utilizing the right equipment to do so. And so when we think about the why less is often more, well, I guess this is twofold, because on the one hand, we need to understand the patient's perspective, but clearly patients need to understand also our perspective. And so we often rely on this very interesting chart here from McKinsey International. And again, you can flip the word patient to dentist, but the concept is, when were we born? And based on when and on many levels where we were born, we tend to behave a bit differently, and we tend to consume differently. And particularly behaving and consuming has to do with the way we embrace technology. And some of us are earlier adapters, and some of us may be a bit late adapters. And at the end of the day, I think working in a field like dentistry, we cannot stay behind, and we have to be on top of the curve and try to push the boundaries and embrace whatever comes our way from a technological standpoint. Ultimately, the whole notion of embracing technology is about being predictable with what we do, being consistent with what we do, and getting from point A to point B, having a smoother ride than if we were to choose the conventional approach. This holds true when we look at analog dentistry versus digital dentistry. But on many levels, as we will be mentioning right now, it also has to do with, embracing laser technology as an integral part of our armamentarium. Now, one thing that is interesting, and again, looking at all you folks connected from all over the world, I can tell you, and I hope you agree with me, that the perception worldwide is that the type of dentistry that we practice in North America, and by the way, Mexico is part of North America, it's on many levels seen or perceived as if we over-treat patients. And this holds true across the board, not only dental treatment, but also medical treatment. A healthcare professional is perceived as individuals that over-treat conditions. And our contention, what we really want to bring across the board, is that conceptually, our treatment design should be geared towards less invasive nature, being able to provide to our patients, as I said, the best possible means of solving whatever it is that their condition may be with the least amount of procedures. Now, the reality is that a lot of what we do in dentistry is repeating old dentistry. And mainly when we go in and we try to help our patients redoing dentistry, a lot of that dentistry has been incredibly invasive to begin with. And so, we end up truly struggling, working with many patients that have very little tooth structure left, or that have very invasive restorations. And so with this in mind, a couple of years ago, we wrote this little article in which we try to comprise or condense all this treatment philosophy of the less is more, basically within 5 elements. And these 5 elements have to do with, on the one hand, being as careful as we can to preserve tooth structure. Number 2, to be able to, or to try to involve the least amount of teeth in whichever procedure we're doing. Number 3 has to do with utilizing the least invasive technique or techniques. Number 4, delayed treatment whenever possible. And finally, phase therapy whenever possible as well. And so today we want to focus mainly on number 3, which is utilizing the least invasive techniques. And with that in mind, we want to introduce you a set of parameters or a set of procedures in which we feel very comfortable managing our dentistry utilizing, our water lace unit. And so conceptually, when it comes to the dentistry that we do, we can think of restorative procedures. And within restorative procedures, we will typically utilize a laser to remove ceramic veneers, or for that matter, full coverage restorations that could be made with materials such as lithium disilicate. Even some people advocate also removing zirconia crowns. We hardly do so, but mainly removal of ceramic veneers. Of course, also doing some troughing, gingival troughing to optimize our impressions. And of course, eventually also utilizing the laser for caries removal. Now, when it comes to surgical procedures, and these are only but a few of the surgical procedures that you could utilize a laser for, but conceptually for today's webinar, we're going to be concentrating only on these first 4, some gingival recontouring, phrenectomy, lesion removal, although clearly we could utilize the laser for a whole host of other different procedures, such as the ones that you see listed here.
Yeah, as Sam was saying at the beginning, we know that you've had exposure to a lot of the periodontal treatments that we can use a laser for, and we definitely use it for perio quite a bit as well, and for periimplantitis. But since we only have like 45 to 50 minutes, we wanted to mainly focus on the title, right? Achieving aesthetics. So we're going to be focusing on these treatments that Ricardo just exposed right now.
So conceptually, when we have patients coming in with ceramic veneers that require a change of them because the patients are no longer satisfied with the aesthetics of it. So why would we even think of utilizing the laser unit? Well, And this is the question that arises all the time when we're challenging previous technology. Why utilize something if the conventional approach works so well? Well, I guess we can all argue that while removing previous restoration, particularly ceramic veneers, it's almost next to impossible for us to be able to do so with a conventional diamond burr high-speed handpiece without removing at some points unnecessarily some sound tooth structure. And so, as you will see, utilizing a laser unit becomes an incredibly compelling and useful approach to be able to remove the veneer and make sure that we're able to retrieve the veneer, basically just go back, access the tooth preparation, and be ever so slightly, as minimally as possible in order to achieve the right aesthetic results that we want. And so with this in mind, we published this article, and I'm happy to, in the chat function, as we are answering questions, I can either just add the link or please just once again, reach out to us and we'll be happy to send you the links if you want to review these publications more carefully. But the bottom line, what we found in our clinical experience is that while removing ceramic veneers utilizing our laser unit, you can have 3 different modes of removal, if you will. Sometimes you're going to get a very clean cut removal in such a way that you retrieve the veneer in an intact fashion. Often you're going to experience also having some fracturing components. It's just, you see that it cracks and you basically remove some fragments of the veneer. And in some instances, as we're removing the veneers, you'll notice more of it like a shattered ceramics, which in any way works greatly because once again, we're able to retrieve the veneer and then just see the resin cement that the previous clinician had utilized. And so quickly, we're going to walk you through some of these examples. This, as I mentioned, in those cases in which utilizing our laser unit allowed us to retrieve the veneers in a very, very minimally invasive fashion. And some of you may argue, why are you removing the veneers to begin with? Well, the patient wanted longer teeth. You know, beauty is in the eyes of the beholder. This patient did not like the aesthetics of it, wanted wider teeth and longer teeth. So in any event, we went ahead and removed them. And you'll notice right here, what a clean cut procedure we're able to do. So we retrieve the veneer in the least invasive fashion. Another case here in which, yet again, we're utilizing our laser unit and beautifully, these veneers end up just popping off. And we're going to show you here a little video where you can see diagrammatically what the procedure sort of looks like. And you'll see here that the laser here is located at, as you will see, 90 degrees from the tooth. We typically utilize this as an angle. And so it also says closing the tip closer to the 1 millimeter. When we utilize our turbo unit, we normally, we don't get so close to the veneer. We typically stay away between 3 to 6 millimeters. What's interesting though about this motion is that's called the scanning method. Notice how the tip of the laser is essentially scanning the veneer, the facial aspect of the veneer, going from mesial to distal, pretty much scanning the whole surface of the veneer. And so you do this for a couple of minutes, and then you'll notice that the veneers will pop out very, very smoothly, right? Oops. And so again, these are some of the parameters, Jack, that we utilize, and you'll notice here, these are parameters for the turbo handpiece. And as you will see, we can utilize also the gold handpiece to remove the veneers. It's not specifically for the turbo, but this is, and these are pretty much our preferred settings when utilizing them to retrieve the veneers. And so just quickly show you how, as you can see in these images, we're able to remove the veneers. They come out very, very smoothly. And then it's just a matter of cleaning up the prep. And here we wanted to change the long axes of the teeth. So we had to open up the midline here to correct because there was a midline discrepancy here. So we went ahead, we did a provisional restoration right after we made our impression. And here you can see the ceramic veneers and the insertion of the veneers. And so very nice before and after, in which you could notice that we did change the orientation of the midline by opening the interproximal for a bit and allowing to create the right contours for the veneer. But the bottom line here, utilizing the laser unit to be able to retrieve the veneers as minimally invasive as possible. And by the way, from a patient communication standpoint, patients really appreciate the fact that we're utilizing a technique that, again, allows us to be able to retrieve the veneer with the least invasion. Again, not that it was wrong removing it with a conventional high-speed handpiece and a burr. Problem, though, is you ultimately end up, even if you do it as carefully as possible, removing some sound tooth structure, right? Here's yet another example in which you'll notice here there's a little bit of a crack again, but the retrieval nature of the veneer, again, is very straightforward. You'll notice how almost intact we're able to remove them. And then again, just refine the preps, make impressions, send them to a lab, fabricate the new veneers. And here you can see, the ceramic restorations. This is an interesting case in which we're utilizing the gold tip. And this patient, by the way, is a patient that had been utilizing this veneer for quite a while. She's had them for 30 years. And so it's interesting for us to have a little discussion here, because you will notice that at some point you will want to change your parameters based on potentially the thickness of the veneer and the bonding protocols that were utilized when bonding this veneer. So clearly 30 years ago, we did not have the bonding agents that we have today. We didn't have the protocols that we have today. We didn't have the ceramics that we have today. So we're looking here at a thicker veneer. And here you'll notice we're utilizing the gold tip. And lo and behold, as we're removing here these veneers, and you'll notice here that these are the parameters that we utilize now for the gold handpiece.
So we usually, as Ricardo was saying, you can use both, either the turbo or the gold handpiece. Both work well. We usually or typically use the turbo handpiece because it's a little bit faster. We change the parameters a little bit because of the focal area of the laser and how the laser works. So we're giving you both examples. In case you don't have the turbo, you can still use the gold. You just have to go very slowly. This scanning method, as dentists, we're used to going pretty fast with the burr, right? We have a high speed electric handpiece, and we have a thick burr, so we go very quickly, and you have to just train your hand to go a little bit slower with laser in general, to make sure that the energy of the laser gets transmitted and gets absorbed by the water in the cement. So here are the parameters. If you want to use the gold handpiece, we typically use the MZ6 tip, which works really good for these cases.
So again, the same concept of the scanning method. We go from facial, from mesial to distal, right? Making sure that we're able to scan throughout the veneer. And so here you'll see what that quote unquote shadow removal looks like. You see, it's the brilliant aspect of this removal is that now you can go in with your burr and just remove that resin cement, creating your finish line for the new veneers, ensuring that you truly were able to go in and prep to the least invasiveness possible. So this is what we're doing. This is now the removal of that resin. Then we place our retraction cords, and then we have here the fabricated veneers, and we're able now to seat them in place. So I guess take-home messages here that are important for us to touch upon. So settings may be altered, as I said, based on the material of the veneer, and typically you can have either feldspathic veneers or lithium disilicate veneers. Typically the feldspathic are going to be thinner veneers, and also, of course, the thickness The thickness of the veneer, ultimately, it's going to be contingent upon the corrective nature of the veneer, right? If you want to bring the teeth more facial, if you want to do whatever aesthetic correction you're deeming you want to do. But typically, though, the veneers are going to stay in the thinner end. Now, when you're replacing veneers, it's just a matter of removing the old veneer and kind of figuring out where you're at as far as the prep goes and the thickness of the veneer. So we will notice that there's variability between the thickness of the veneers that we are retrieving.
Yeah, and also one tip that we've used before is when you have a very thick veneer, you can start with a burr just to like go halfway through the veneer, or even like 60-70% of the ceramic, or even a crown. That way you make it thinner, and then you go back to using your laser, and then the energy of the laser is going to get absorbed by the cement. So if you're trying to use the laser and you're not seeing the shattering or the removal of the veneer, you can always make it a little bit thinner and then use the laser to make sure we're minimally invasive as well.
Right. So you do a preliminary preparation with a burr, and then you go back with the laser. And if you think about it along these lines, we'd like for you to consider this important key, because you don't want to stay putzing around with a single tooth for too long. And so you want to avoid having any type of pulpal damage. And our friends, the endodontists, tell us that ideally is that after spending in the neighborhood of 2 minutes attempting to remove a veneer for a single tooth, if you don't succeed, you may want to go to the next tooth for a minute. That way you let that pulp recover a little bit, and then you can go back and hit that tooth with a laser again. And you'll notice that typically you're going to have great results doing that. And you go with your Explorer tip, you go to the margin, you try to tease it out, and you will see how essentially the veneer just pops out like a cork in a bottle, right? Next item up that we utilize quite often is for troughing. If you have excess tissue around your margins, it's always a great idea to remove or to excise that tissue. We utilize, way back in the day, we could utilize electrosurge, but the laser does such a much cleaner job by enabling us to, in some redundant tissues around, particularly molars, we can go in and trough and then make our impression.
Yeah, and that makes it much more efficient also in like private practice, as we do here. Like we used to have to adapt a temporary, make sure that the patient was using chlorhexidine rinse, and then ask them to come back a week or 2 weeks after that to take the impression. Now with laser, we can make the preparation, do this troughing, take the impression the same day, and we usually see them a couple of days or a week after that, and the tissue is very healthy, so we're able to bond that crown or that partial restoration, and it works really good, and it makes everything more efficient. Now here, when we're using troughing, we're giving you what we use mostly for our laser parameters, but in reality, us with the water lace that we're using, the I+, it comes with a little screen, and it's amazing because you can just touch up on whatever procedure you want to do, and it comes with all the pre-loaded parameters. So you don't have to remember all of these. We've changed a little bit with experience, and we change a little bit with every case we do. But in reality, the parameters that BioLace gives us are pretty amazing. So we sometimes increase a little bit the water in some of the cases, and I mean you'll have the information here, but also you can talk with your BioLace rep, and they can help you with the parameters as well.
And so again, when you look at the full array of potential surgical procedures or other procedures that you can utilize the laser for, I mean, they're pretty broad. One of our preferred endodontists here that we work with all the time, Dr. Isaac Kabli, is a champion of laser. He actually just finalized a master's degree in Germany with lasers. And he's been a huge proponent and a huge advocate and a huge coach for us to keep on utilizing lasers more and more. But I guess what I'm trying to say is that there's such a broad array of procedures that you could utilize a laser in a day-to-day practice. So what we want to do today is basically share with you a few of these very clinically relevant and common applications that you will bump into in your practice. And again, give you the gist of it, give you walk you through the step-by-step approach. And as Jack said, we'll give you some parameters, but the beauty of the unit, which is like a Tesla of a unit, is that you have their tremendous display where you can basically just go through the different displays, and essentially you're basically just pressing on what you're requesting and you'll get all the parameters yourself. So with that, Jack, let's go ahead and walk them through all these different procedures.
Yeah, thank you, Ricardo. So one of the main questions that we get is why use the laser, right? I mean, we were able to do all of these procedures before using the laser, and it's rare that we find a procedure that we're not able to do before the lasers. So what are the advantages? And we're going to go over all of these procedures, but main advantages is that as we're working with the laser compared to the electrosurgery that we used to do before, the photo sensitivity that we're getting from the cells and the ablation that we're getting from in the way that the cell will absorb the energy of the laser, it makes it so much easier to work with. It makes the post-op much better for the patient. Like when we do these cases, we call the patient the next day and the patient says, I mean, I'm perfect. I don't have any swelling. And like most of the cases for the simple surgeries, we get a great result from the post-op. And you're able to control the bleeding, which is something that you're not able to do when you're using a traditional blade. So we're going to go over some examples to share with you what we do here in our practice. So we get some cases with these lesions. Most of them are because of trauma.
And so, just by the way, real quick, as important as the effective nature of the procedure, again, from a psychological perspective to the patient, the fact that the patient hears that we're going to be removing a lesion in which there's not going to be a scalpel blade, there's not going to be a knife, but there's going to be a laser tip. That right there takes quite a bit of the anxiety away from the procedure, because let's face it, patients don't like our chair. And if they know they're coming in for us to cut tissue away, you know, emotionally, they're not as happy as if they walk in and we let them know that this is going to be, you know, a scalpel-free procedure or a knife-free procedure.
Yeah, for sure. And just to clarify, the purpose of today's webinar is to talk about the erbium chromium, which is the water lace the brand is BioLace that makes the water lace unit. We also use the diode, which is the Epic, and that we use it for different purposes. And sometimes we combine both lasers. So today we're mostly going to be focusing on erbium chromium, which is the water lace. So again, going back to the case, we get these lesions, which most of the cases are because of trauma. So we get these traumatic fibromas, and it's not 100% necessary to remove them because they're benign, but a lot of the times the patients are uncomfortable with these types of lesions, either on the tongue or on the cheeks or on the lips aesthetically, or they can bite on them and they're not very comfortable. So it's a very simple procedure to remove it with a laser. We've done it also with just topical anesthesia. Here we did some infiltration, but now more and more we're using topical, because one of the beauties about laser is that as it's working its way through the tissue, if you use the parameters correctly, it's not that painful. So we can do it also with topical. So here we're localizing the lesion, and here we're using an MT4 sapphire tip, which gives you a very, very clean cut. It's almost like a 15C blade. And here are the parameters that we're using the gold handpiece. And we just go very, very gently all around 360 around the lesion. You can use both H mode or S mode. If you see that you're having a lot of bleeding, you can change to the S mode for soft tissue. And that way it's going to be a little bit slower, but you will have a little bit less bleeding. So as you see here, we're going through and we're taking a couple of pictures, and we don't get that much bleeding as if we would have done this case with a blade. Can you do it with a blade? Definitely yes, but probably you would have to add some sutures as well to control the bleeding. And here, as Ricardo was saying, the patients love the idea of not using blades and not using sutures and make it a more straightforward procedure.
And as far as the recall goes, I mean, patients really go through a very smooth post-op, and that's another consistent feedback that we get from them, that they're incredibly comfortable with the procedure.
Yeah, 100%. So that's one quick case about lesion, and we use it quite a bit. Another great example is a phrenectomy. So we use it. I mean, I would say since we got the unit, I would say probably 100% of our phrenectomies are done with a laser. Here we have a case of a patient that had big diastema in between the centrals and wanted to close that space using aligners. So first thing we see is that we have a very long frenal attachment in that area. And even if we try to bring the teeth together, they're not going to stay in place because we have all the fiber attachment there. So we go through the process with the patient. We explain that to the patient. And once we have all the documentation, we do take radiographs and we do all the analysis for the patient. You can see here on this lateral picture how we have a very, very long attachment in the area. And we're using a MZ6 tip for this case because it's going to be a big phrenectomy. And we want to show you here with the animation before we go into the clinical pictures very quickly how we can use the laser. And as I said, we don't use sutures anymore for these cases in most of the time because we get a very clean surgical area, and that's very nice for us and very nice for the patient as well.
So I guess Nathan is asking here to clarify, says, do you mean that phrenectomy is better with the water lace compared to traditional methods? Well, it's not that it's better. It's, I mean, from an efficacy or efficiency standpoint, you could definitely utilize the conventional method. But what Jack is alluding to is it's a simplified way of doing it. And as we said, the post-op is phenomenal, and patients really go through a very smoothless ride.
Yeah, you can see here in the animation, and you'll see also with the clinical pictures how, I mean, you can very clearly see how you're going through the fibers when you're doing this procedure in a patient. And also if you have a little bit of bleeding, you can always use the laser bandage part or the parameter, and you can clean everything up and the patient goes home without bleeding. So here are some of the parameters that we use for this type of procedure. So as we were saying, it was a long phrenectomy. So we made sure we went through all the way in between the incisors to make sure that we had, we removed all the fibers and that we were able to close that diastema. So here, yeah, it's a little bit bigger than what we usually do, but it's what the patient needed, right? So these are pictures right after we finished the phrenectomy. So you can see there's hardly any bleeding in the area. And then, of course, we started with the clear aligners. This is a week after. You can see that, I mean, it's healing up very nicely. And then you can see 3 weeks after the procedure, I mean, there's almost no sign of the surgery, and we have a nice result. And you can see the new attachment of the fibers is higher up, and that's what we wanted. So you can see now the patient is still in ongoing treatment. We're still finalizing and want to make sure that we close that gap completely, but we're very happy with the result, and the patient had a great experience during the surgery as well. Couple more pictures just to show the progress of the aligner therapy.
All right, so let's now discuss a couple of cases in which we're doing some gingival or osseous recontouring. So this is our patient Marbella, who came to see us with very specific concerns. You can notice here, both in this facial picture as well as the close-up view of the smile, that she does have rather undersized teeth, particularly the laterals. They do appear to be on the peg-ish size or form, if you will. And so in this close-up view, we could readily see that even though the laterals are really small, there's still lack of that dominance of the central incisor that we typically like to see aesthetically, where the gingival margins of the centrals normally will coincide with the gingival margins of the canines. And so this is what this picture looks like. We look at the radiographs or a close-up view here. And again, it's very, very critical for us to figure out exactly where is that CEJ, what we're looking at here, in spite of the fact that we have a this short clinical crown. You will notice that, I mean, we don't quite know if we have what's known as an altered passive eruption or an altered active eruption. We need to know where the bone is. We need to know where the CEJ is. Now, while this is very important because it will dictate the type of procedure, the plastic periodontal procedure that we need to do, it does make sense for us to present to the patient the what if, the how would the patient look if we were to carry out this aesthetic enhancement. And so one way that we as restorative dentists typically communicate with patients is via a mock-up. So in order to do this, you could either do a digital wax up, and then from this you could either 3D print, or you could do conventional aspect in which you do an actual wax up, then you do a silicone matrix, and you do a mock-up so that the patient can now see where we're bringing that gingival margin to a more equigingival compared to those canines, and also raising the gingival level of the laterals. And the same deal, we're able to depict this in this full-blown smile. Now, this allows us to communicate with the patient. The patient sees it, and patient realizes that she does like the enhancement. She's not 100% sure about the veneers, but she's pretty sure that she does want to have more dominant teeth. Now, if you go back and take a look again at the soft tissues, well, we clearly see that our prescription here is going to be twofold. On the one hand, we need to reposition that gingival margin of the centrals and laterals a bit more apical. But what do we see right here? Well, we also have a sort of a lower frenum attachment, which means now that from a wish list, from a prescription, we need to ask our periodontist or our restorative dentist that is going to be performing these procedures to do both a gingival or gingival osseous recontouring, depending on where the bone is, depending on where the CJ is, as well as a phrenectomy. So Jack, so basically here you can see the images of both the recontouring as well here as the phrenectomy. And so here we're going to basically just show you the animation of how this procedure when uncovering. And so the deal here is you first scallop the tissue to get it where you want it to be, and then you see your probe, you see where the bone is, and then ultimately what we need to go is closed flap, recontour the bone. And you'll notice here that we're basically wanting to do this only for these 4 teeth. This is not entailing, the full arch. The canines were where they wanted to, were basically had the gingival margins where we wanted them to be. So this correction is only going to be limited for those 4 teeth, both centrals and the lateral incisors. So,
now, one of the beauty of these lasers is that, as Sam was saying at the beginning, it's an all tissue, so hard and soft tissue. For example, the diode or the Epic, it's mostly for soft tissue and pain management and other areas. But this laser, you can use it for both soft tissue and hard tissue. That means that we're able to do this closed crown lengthening with the same laser. We're just changing the tip in this case. So we're starting with the MT4, which is a very thin tip. And then when we go to the bone, we're going to change the parameters a little bit and change to a MZ6, as we're showing in the animation right now, to go in and remove that bone. You can mark your tip where you want the depth to be. As Ricardo was saying, you check with a probe, and then you can mark the tip, or you can keep checking with the probe, whatever you feel comfortable doing. And once you're done with that, you're gonna smooth all the area of the bone, and you're doing it with a closed flap technique, and that makes it much better for the patient's post-op as well.
And so here's where we've heard it gets tricky for some. It's very important to, as there's the bone recontouring, to go in with a burr and make sure that that ledge of bone is both thinned, but we also have that enough thickness to allow for that biologic width to have the right amount of tissue there. Otherwise, what you end up seeing is that there's creeping of that tissue. If the bone is not positioned to where we want it to be, which is typically 3 millimeters apical to that proposed gingival margin, we may have some rebounding of the tissue. So again, this is done for these 4 anterior teeth, which works very, very nicely. Again, here you can see the parameters. The Jack utilized it here. It's the gold handpiece with the MZ6 tip. And then just as he finalized doing both the soft tissue and bone recontouring, then he starts working on the Phrenectomy.
Yeah, so we do what we showed in the last case. So very similar technique for Phrenectomy. And again, here are the parameters that we use for Phrenectomy. And as you can see, we change a little bit based on if we're using soft tissue or hard tissue. And this is the picture right after we finish both procedures. And you can see how it heals after a couple of weeks.
And so the patient is ecstatic with the aesthetic results. And in fact, she says, well, I'm so happy with the way the teeth look. I would like to have them a bit wider. So we go ahead, we do some bleaching. And in a situation like this, in which we spoke about potentially enhancing the contours of her teeth with some veneers, she was so happy with the result here that we basically just sat here. This is where she was happy. Our interdisciplinary management of her was essentially soft hard tissue management and then some bleaching, and off we were. We did not have to add any additional restoration. So when you think about what was this patient's journey and how this connects with that so-called less is more philosophy, you'll notice that for this particular patient, we're able to score in the 3 different aspects. We are preserving all tooth structure. The teeth and ball were only those needed, and we utilize the most with the least invasive techniques, both with laser and of course with bleaching, and we attained the best possible results. And we have an incredibly happy patient, a patient that becomes a raving fan of the practice because she leaves the practice saying, wow, I didn't even need to go through the veneers. I'm happy with the way things turn out. And the veneers are always an option if and when she feels like we want to, customize her smile, adding some contour. And if that's the case, we would probably be able to do some restorations with as minimal preps as possible. And so with that in mind, we want to share this last case in which there's a lot of talking points here. This is a patient that was previously treated, and it's a patient that's concerned with the aesthetics of the veneers, but also she's concerned with the aspect of her soft tissues. You'll notice that there was some recession associated particularly to the lateral incisors. She seems to have pretty triangular teeth here. And so what the previous dentist did was basically extend that margin of the near and the lateral all as apical as the recession existed, right? And so this clearly is an aesthetic issue for this patient. She does not like the aesthetic outcome of this. She's actually very concerned. She's very disheartened. And so, in this spirit of talking about minimally invasive dentistry and procedures, and Sam being a periodontist, and I know many of you are periodontists as well, I mean, we should point out that gingival recessions are not neither glass ionomer deficiency, nor composite deficiency, nor ceramic deficiency. Gingival recessions are soft tissue deficiencies. And so how do we address this type of situation now that we're entering her clinical situation and we are now correcting things? Well, this is what we need. Our goals of therapy have to do with optimizing tissue. So we need to correct the soft tissue architecture. We need to thicken the keratinized tissues. And ultimately, we need to replace the ceramic veneer. So you'll see how interesting everything plays here. Now, this is a procedure that Jack and myself didn't do. This was carried out by Dr. Salvador Garcia, a phenomenal periodontist here in Mexico. And we start out by undermining the contours of those ceramic veneers. We're creating enough space so that now our surgeon can go in with micro blades and he can carry out this dermal matrix grafting protocol. Here you can see the dermal matrix and how he's beautifully now positioning everything in place. Do you care to comment anything on the technique?
Yeah, I mean, it's a technique that we use quite a bit. It's a tunneling technique, and we don't have a lot of time to go in depth, but it's a tunneling technique. We sometimes use dermal matrix, we sometimes use connective tissue, or we combine both depending on the case. Here we decide to go with a dermal matrix, which works very well, and we're able to get a nice result by gaining or covering the recession, covering the roots, and also thickening the tissue as well.
So here we can see the before and after at this point when we had maturation of that grafting material. And here you can see the comparative of where we were at initially and what we were able to gain through this grafting. And so now the question is, what is the least invasive technique to remove the veneers? Well, I hope you all by now know that we are going to be utilizing our laser unit, and you will see here, utilizing the turbo, how beautifully we're able to retrieve the veneer and just see those traces of the resin cement with which those veneers were luted. In fact, you will notice here in these pictures, we've removed now one side. Here we've removed the full 8 veneers. And so notice from this transition how it's just a matter of cleaning up, that resin cement, creating a new margin for our new ceramic veneers, utilizing our retraction cord to make sure that we have a clean impression and that all these margins are adequately transferred to the laboratory. And some of you may be utilizing now intraoral scanners and utilizing iOS protocols to transfer this information to the lab. This year we started utilizing pretty diligently as often as we can our digital scanners as well. So here we do our preliminary provisionalization, and here you can see now the ceramic veneers fabricated by one of our very talented technicians here, Mr. Eladio Gonzalez. And here are some different aspects of these beautiful veneers. You'll notice how he works with the line angles. Another final aspect here of the veneers in a crystal slab prior to bonding. So we try them in, and here you can see how we've enhanced the contours, but how we've stayed pretty much in the realm of minimally invasive. We're still in enamel in most of these preps, which is, again, one of the virtues or one of the tremendous advantages that we're able to continue having by the means of utilizing our laser units. So here are the veneers in place and a composite images of different aspects of how these veneers integrate in our patients' full-blown smile. So a really, really happy patient. And of course, as usual, we want to see where we were coming from, what was the initial presentation, and how now we're able to provide the patient with the right amount of soft tissue, with the right ceramic restorations, again, retrieving the previous one, removing the previous one, the least invasive approach. So we are awfully close to finishing up. I just want to remind you the 3 different modes of removal. You can have like the intact, you could have some fractures, or the shattering. And again, remind you that where we are today in dentistry, as at the intersection between healthcare, lifestyle, and technology. And as we go to Q&A, if there are any questions, we'd love to leave you with this very powerful quote by tremendous restorative dentistry that lived in was very famous in the 70s and 80s, Dr. Bob Barkley, that says that the best dentists will try to make the patient's worst at the slowest rate possible. And if you think about it, when you read between the lines, this is what we should strive for: doing the least amount of dentistry, doing the least amount of harm. And this is why we're such strong proponents of the less is more. We're such proponents of utilizing the right technology, the right procedures, the right means to preserve our soft tissues and our hard tissues the best we can. And this is why we believe that, utilizing technology just like the lasers, truly enhances our practice and truly enhances our patients' experience. So with that, we're going to invite our friend Sam over, and let's have a small discussion here before we send these whole folks to have a little break after our long discussion here. So Sam, what do you think?
Great. Thank you both, Ricardo and Jack. Love the comprehensive care, the integration, and the minimally invasive part, because that is where oral health care is going. There's a few questions, and we'll make our time limited here, but one question that I think is very important to the audience, and that is, someone did ask, can you do this with your diode only? I'm talking about the aesthetic crown lengthening. I have some answers, but I'd much rather have it from you. Can you do this with the Epic X that you now have?
You are the expert, Sam, but my quick answer would be, if you're dealing with soft tissue, the answer is yes. If you're dealing with bone, then you might need to add some additional procedures. But soft tissue only works great with a diode.
Right. But probably nobody better than you to answer that question, dear Sam.
Well, but I enjoy the fact that you are dentists, you're prosthodontists.
Yes.
And you're dealing with veneers all day, and we deal with this whole, supracrestal alteration now, or AKA biologic width. Mm-hmm. And to the individual that asks, yes, if you can predict that you're not going to get into a biologic width issue, then yes, a gingivectomy with an Epic is an alternative. But if you missed it and you do get into bone, you can't go backwards. That's the problem. You'd have to reflect a flap, right? You'd have to reflect a flap and then do your biologic width.
Some people, yeah. And you being a parent, I don't know if you're okay with this. Some people advocate if you do your gingivectomy with your Epic, you're not 100% sure about going in and removing bone. Depending on the phenotype of the patient, you could also go in with a Gracie curette and try to remove
exactly
the bone with a curette, and so utilize the Epic. And typically, where you don't want to miss that biologic width, where typically we don't do a good job, is remember that the gingival scallop is going to follow the bony scallop. Now, when you're doing a gingivectomy, what you want to make sure is that you see that phenotype. You see that's your bone both buccolingually, but also mesial distally and apical coronally. So you want to make sure that you go from line angle to line angle, in which you're able to smoothen where that bone is.
Right.
So I don't know if this makes sense, Sam.
Oh, it does. And actually, I was speaking with John Coyce not too long ago.
Yeah.
And actually, Dr. Coyce actually created aesthetic crown lengthening by doing a blade gingivectomy back in the day and using an in-cutting burr to remove the osseous. But now he's come also up, by the way, I'll just tell the audience, to look at something called, I think it's Brassler. He has created something called the Kb1 Chisel. And, where you were talking about using the curettes, or even I use chisels after even doing the laser.
You bet.
And you do too, just to ensure, because you demonstrated at the line angles is where you get burnt. If you don't remove the osseous at the line angles, and I love your comment, gum follows bone, gingiva follows bone exclusively. You know, using the laser, and thank you for giving us the settings, but there was a question about, well, if this is a laser and it also can work on bone, am I going to hurt the teeth when I'm doing these kinds of things, whether it be troughing, whether it be the aesthetic gingivectomy kind of, am I going to hurt the teeth? So what would be your response? Are you worried about hurting the teeth?
It depends on the amount of energy you're using. So the laser works mainly on the hertz, so all the pulses per second, and the watts, right? So the amount of the watts is the amount of energy that, I mean, I'm not going to go into detail, but the amount of energy, let's say that the laser is kind of like using, and then the hertz is the amount of pulses per second. So if you use a lot of hertz and like high number of hertz and high number of pulses per second, you get into the area of the laser that works on tissue, hard tissue, bone, enamel, dentin. So if you don't use it properly, you can potentially get into trouble with the teeth. If you're using the right parameters and you're using it for soft tissue, there's no problem with touching the tooth because nothing is going to happen to the enamel.
Let me ask you both on the aesthetic crown lengthening. When would you not do it? When would you say, wait a minute, I'm either going to refer it or I'm going to reflect the flap myself? When would you not do closed aesthetic crown lengthening?
When we have to do quite a bit of tissue, let's say if we're not sure that we're going to have control over the result, or as Ricardo was saying, we sometimes get cases that we have a lot of thickness of bone. So we have like exostosis, or we have a lot of buccal bone, and
right,
in different areas, different width of bone. And it's difficult to, I mean, I'm very comfortable controlling the height with the laser, but the width is a little bit more difficult. So if we're not 100% sure that we're able to get a nice result, we just open a flap and we do it traditional. And there's nothing wrong with doing it traditionally. Again, as you said, these are alternatives to treatment.
Yeah. And we just, by the way, for the audience, if you take the International Journal of Peri and Restorative Dentistry, in the January-February issue, Walid Altiyab from Qatar and myself and others, Giorgio Romanos, we just published the first randomized controlled trial of doing flap versus closed aesthetic crown lengthening with the erbium chromium. And the results actually were the same. Which, you know, there's certain individuals out there that believe you can't do it, that you have to reflect a flap every single time. But this randomized controlled trial, we soon will publish the patient-related outcomes showing at 7 days, a very decreased bleeding, very decreased discomfort. And moreover, they like the way the aesthetics are because they were able to see it, you know, fairly immediately without the suturing and so forth. I love the phrenectomy, Jack. Tell the group a little bit about how you do any post-op or any issues that you have post-operatively that you're looking at.
No, I mean, traditionally, as you know, Sam, we used to do the phrenectomy with a blade, and we used to suture the tissue where we wanted to keep it, right? So we used to go high up and suture the tissue there. Now with laser, I rarely use sutures. We mostly just go in with a laser. We've done sutures where we see that we have very, very thick phenotype, very thick tissues, very fibrous tissues, and that we see that it's going down because, I mean, ultimately it's going to heal where the position of the tissue is. But yeah, I mean, the beauty is we don't have to use sutures. It's a very quick procedure. We don't have a lot of bleeding. As you say, the patient can see it immediately, and that's something that the patient likes. Post-op, I mean, usually the next day, the patients have no bleeding. I mean, they leave the office without any bleeding, and the next day they're back to normal life. So we see them 1 week post-op, and we see a little bit of the, you know, the soft tissue getting the red getting pinkish. So there is some healing process going going in the area, but definitely we have a faster healing when we use the laser compared to traditional techniques because of the photoablation and all the things that are going on in the cell.
And we consistently get, patients raving about it, saying, wow, I can't believe what a great post-op we're having. So, it's just different. It's a game changer.
Right.
Any levels.
And also, sorry to add on something, but when we use only like gingivectomy, when we're only removing soft tissue, that we're doing it with a topical anesthesia, that's even, patients love it because we don't use any anesthesia. So that's also like something major for the patients.
I'll answer a couple of these questions. One of them is, do you make contact for bone removal with the MC6 tip? And I love, Jack, that you mentioned, this is not a high-speed handpiece. You hit it right on the head. You have to go slow. But we do make light contact with the osseous, with the bone, with the MC6, very light, if any, because if you touch it like a handpiece, you have no distance between the tip and your target with the water, because it is part of the way it works is the laser energy is seeing the water and causing microimplosions. One was, how bad can the effect be on hard tissue with wrong parameters? Well, if you use the less parameters, it's not going to do anything. If you do too many parameters, we do appreciate that. What would happen, Ricardo? What would happen if we tried to, we forgot to use the same setting you're going to use with your turbo for a veneer that you used on the bone?
So what happens if you?
Well, the question is, can I hurt anything if I'm using the wrong parameters?
Well, if you don't use the right potency, you're not going to be effective doing what you want to do. And so you want to make sure that your tip is adequate, and you want to make sure that your parameter is adequate. Otherwise, you won't be effective, in the task that you want to do, whether removing the veneer or excising or cutting the tissue away, whether it's bone or it's soft tissue. Can you hurt the bone? Well, as I said, you don't want to spend too much time doing a procedure that's not going you anywhere. So you've got to make sure that the parameters are right. And for that, you can't go wrong by just looking at the parameters that are provided by your own unit.
So this question is a little tongue in cheek, but
yeah,
prior to getting it, and I remember when we were at Spear, and you and Jack have taken this thing to a whole nother level. And I enjoy it because you're prosthodontist, showing that you're multidisciplinary. But if I took the laser away from you and you had 4 veneer cases that needed to be removed tomorrow, what would you do? I'm being facetious.
We would cry.
So yeah, once it's like any type of technology that you start utilizing, and that now you start being an immigrant into that technology, but then you make it yours. You really struggle, going back to the analog fashion, if you will, right? Not that you can't do it. Fortunately, we are quote unquote analog or cognitive dentists, that we were trained in a conventional way, so we can go back and do it conventionally. But we would feel that we're not doing, I wouldn't say a disservice, but we're not doing the best job that we can if we're not removing the veneers in a way. Again, Sam, this whole notion, this is why I'm including this philosophy of ours that basically has these 3 pillars, right? Being the least invasive with tooth structure, trying to limit your dentistry to the least amount of teeth, utilize the least invasive protocols, delay dentistry, and face dentistry. If you look at those, the linear fashion of those 5 pillars, we believe that by doing so, we're providing the best quality of dentistry we can to our patients. And so when you ask me to stop utilizing one of them, can I go that route? And the answer is yes, I could, but I would feel so much more comfortable, doing whatever I possibly can to ensure that I'm delivering the best result possible.
Well, thank you very much. You've really presented there's no doubt about the whole iconic future of oral health care, or present, as you're doing it in Mexico City, with minimally invasive, what I call minimally invasive oral health care. From that respect, I enjoyed it. It was excellent. Loved the cases. Really appreciate it. I hope the audience, you were able to look at the Instagram possibilities of talking with Ricardo or Jack. They're very wide open. They're the kind of individuals that believe in sharing information. And you did a great job tonight sharing. You're way over my expectations, but I knew the perfection that you do is just really, really, to me, it's the highest bar that can be achieved, and we really appreciate you sharing it. So.